Welcome to Lesson 4. Yesterday, we built the left side of our logic model, inputs and activities. Today, we complete the picture by focusing on the right side, outputs and outcomes. This is where we describe what our activities produce and what changes result. The distinction between outputs and outcomes trips up many planners, so we'll spend significant time clarifying it. Understanding this distinction is crucial because funders, evaluators, and communities care about outcomes, the actual changes in people's lives, not just outputs, the activities we completed. By the end of this lesson, you'll accomplish three objectives. First, distinguish between outputs, outcomes, and impacts. These terms are often confused with real consequences for program planning and evaluation. Second, define measurable indicators for each logic model component. Every box in your logic model should have a way to measure it. And third, articulate the pathway from short-term outcomes to long-term impact. Changes don't happen all at once, they cascade over time. Understanding this cascade helps you plan realistic expectations. Outputs are the direct products of your activities. They're what you produce or deliver. Number of workshops conducted, number of participants reached, number of materials distributed, number of screenings completed. Outputs are quantifiable, you can count them, and they're largely under your control. If you conduct the workshop, you've produced the output. You don't need participants to change for the output to exist. But here's the crucial point. Outputs are necessary but not sufficient for success. Conducting 12 workshops doesn't help anyone if no one learned anything. Distributing 5,000 brochures doesn't matter if no one read them. Outputs measure activity, not achievement. Outcomes are changes that result from your outputs, changes in people, their knowledge, attitudes, behaviors, health status, changes in organizations, their policies, practices, capacity, changes in systems or conditions, the environment, available resources, community norms. Unlike outputs, outcomes are not directly controlled. You can conduct a perfect workshop, but whether participants change depends on them, their circumstances, many factors beyond your program. This is what makes outcomes harder to achieve and more meaningful when achieved. Outcomes are what funders and communities actually care about. They don't care that you held workshops, they care whether people got healthier. We typically divide outcomes into short-term, medium-term, and long-term to reflect the cascade of change over time. Short-term outcomes are the changes you see during or immediately after your program. They typically involve knowledge, awareness, attitudes, and beliefs. Participants know more about diabetes risk factors. Participants have more positive attitudes towards screening. Participants report higher motivation to change. These short-term outcomes are often necessary precursors to behavior change. People typically need to know why change matters and believe they can do it before they actually change. But be careful. Short-term outcomes are not the end goal. Increased knowledge doesn't guarantee behavior change. Many programs succeed at changing knowledge and fail at changing behavior. Short-term outcomes are steps on the pathway, not the destination. Medium-term outcomes involve changes in behavior, practices, or decisions. This is where people actually do something different. Participants get screened, participants change their eating patterns, participants take medications as prescribed, organizations implement new policies. These typically take weeks to months to observe. Behavior change doesn't happen instantly. It takes time for new patterns to establish, and medium-term outcomes are harder to achieve than short-term outcomes. The gap between knowing and doing is real. Your program needs to address not just knowledge, but also motivation, skills, and environmental support to achieve behavior change. Long-term outcomes, sometimes called impacts, are changes in health status, well-being, or population-level conditions. Diabetes incidence decreases, mortality rates decline, quality of life improves, community health indicators change. These take months to years to observe. The lag makes them harder to attribute to your program. Many other factors influence long-term health outcomes. This doesn't mean we shouldn't aim for long-term impact. It means we should be honest about attribution. We can show plausible contribution. If our theory of change is sound, and if short and medium-term outcomes are achieved, long-term impacts should follow. But proving that impact came specifically from our program rather than other concurrent changes is challenging. Visualize outcomes as a chain. Outputs lead to short-term outcomes. We delivered the education, and participants gained knowledge. Short-term outcomes lead to medium-term outcomes. Because participants gain knowledge and skills, they change their behavior. Medium-term outcomes lead to long-term impacts. Because participants changed behavior, their health improved. Each level builds on the previous. And if a link breaks, later outcomes don't occur. If education doesn't produce knowledge, behavior won't change. If behavior doesn't change, health won't improve. This is why evaluation should track the entire chain. If you only measure long-term outcomes, you won't know where things went wrong if they don't materialize. If you track the chain, you can identify which link failed. Every output and outcome in your logic model needs a measurable indicator. An indicator is the specific thing you will measure to know whether you've achieved the output or outcome. For outputs, indicators are often counts: number of workshops held, number of participants, number of materials distributed. For outcomes, indicators are often percentages or rates: percent of participants demonstrating knowledge, percent reporting behavior change, rate of disease incidence. Each indicator should include a target. What level indicates success? If 60% of participants demonstrate knowledge gain, have we succeeded? Finally, each indicator needs a data source. Where will the measurement come from? Pre-post surveys, medical records, surveillance data. If you can't identify a data source, you can't measure the indicator. Let me highlight common mistakes: confusing outputs with outcomes. Trained 100 people is an output. Whether they learned anything is an outcome. Whether their health improved is a longer-term outcome. Keep these distinct, only measuring outputs. Many programs track activities completed but never measure whether change occurred. They can report what they did, but not what they achieved. This is insufficient for learning or accountability. Expecting long-term outcomes too quickly. If you're evaluating a one-year program, you probably can't measure long-term health impacts. They take longer to manifest. Set realistic expectations for what can be measured in your time frame, and indicators without data sources. Saying you'll measure quality of life doesn't work if you have no mechanism to assess quality of life. Match indicators to available data. Let's summarize our key takeaways. Outputs are direct products of activities, what you produce. Outcomes are changes that result, what changes because of what you produced. Outcomes cascade over time. Short-term changes in knowledge and attitudes, medium-term changes in behavior, long-term changes in health status. Each level depends on achieving the previous level. Breaks in the chain prevent later outcomes. Every output and outcome needs a measurable indicator with a target and data source. Without measurement, you can't know if you've succeeded. And track the entire chain from outputs through long-term outcomes. This lets you understand not just whether you succeeded, but why or why not. In our final lesson this week, we'll stress test our logic models using if-then reasoning. Thank you.